Hi, my name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm the director of the Cardiothoracic and Stereotactic Body Radiation Therapy Services and director of clinical trials. PET-CT has revolutionized the way that we consider managing our patients with non-small cell lung cancer. The most important thing that PET-CT has done over the last several decades has improved the sensitivity and specificity of our staging for patients with newly diagnosed disease. There have been many studies that have shown that compared to CT alone, PET-CT increases the rate of finding occult metastatic disease, occult regional disease, and improves the ability to discern the primary lesion in the lung compared to, say, surrounding effusions or atelectasis. However, what's not immediately apparent for those outside of radiation oncology is that it also has fundamentally changed the way we plan radiation treatment for lung cancer. There has actually been at least one randomized trial comparing PET-CT to CT in the planning of radiation for non-small cell lung cancer, and showed again that it was superior in all respects. Being more specific about that, the potential advantages are kind of disparate and unique to each situation. So for example, one way that radiation planning can be improved with PET-CT is with an improvement in the ability to delineate the lesion in the lung itself. Oftentimes, surrounding atelectasis on CT can be quite dense and looked at the same density as the primary lesion. And so PET-CT can often improve your ability to more accurately delineate the true primary lesion. The other way is improved nodal contouring. Sometimes we have enlarged lymph nodes that meet the criteria for being involved on a CT, such as greater than a centimeter on short axis, but they're completely cold on a PET-CT. And so if there's a patient where you're concerned about the extent of nodal radiation, you can oftentimes reduce that by using the PET-CT as a way to be more prescriptive about the location you treat. It's also been one of the key features that's enabled us to stop offering elective nodal radiation for patients getting treated with radiation for lung cancer. For many years, it was the practice to treat the mediastinum from stem to stern to 45 to 50 gray, and then boost the lung lesion to something like in the 60 to 66 gray range. However, there's significant toxicity by electively treating the entire mediastinum. PET-CT was one of the key features that enabled us to stop doing that as a practice as a group. And overall, it's led to reduced rates of things like cardiotoxicity and pneumonitis, at least in retrospective series. However, there are pitfalls. Most centers don't have a PET-CT in their actual radiation department, which means that you are simulating the patient on your CT scanner and then co-registering the PET-CT, merging them in the treatment planning system together. And the patient's never going to be in exactly the same treatment position for the scan versus your simulation. They also may not be in exactly the same phases of respiration. So there are registration errors that are inherent to bringing that information in. And so I often teach my residents that it is not appropriate to automatically segment based off of an SUV value or just auto contour. You still need to use the CT anatomy to guide your decision-making for contouring. Another potential pitfall is for subtypes of lung cancer, such as low-grade adenocarcinoma. Many of these lesions are not particularly avid on PET, and that goes for the lymph nodes as well. So in a patient who has known low-grade adenocarcinoma, one might need to be more careful or circumspect about using that data alone to guide radiation treatment planning. And then the last situation is inflammatory processes. Unfortunately, many of our patients have COPD or significant pulmonary injury, and they're prone to getting things like inflammation or infection. And PET-CT has a difficult time of distinguishing primary tumor lesions from that inflammation. And so if a patient is actively infected or recently infected and they have a PET-CT, it can be very difficult to tell the difference between inflammatory lymph nodes, inflammatory lung parenchyma, and the tumor itself. So PET-CT has been a critical and necessary part of our arsenal, and it's something we use all the time for radiation treatment planning. In fact, to try and plan a patient with locally advanced lung cancer without a PET-CT would be something I would not recommend in 2021. However, it does not replace clinical knowledge and understanding of anatomy and the patterns of spread, for example, for different lesions in different lobes.